We often think of antibiotics as these miracle drugs, right? A silver bullet for almost any infection. And they are. They're an absolute cornerstone of modern medicine. But what happens when that silver bullet starts to lose its punch? That is one of the biggest challenges we're facing today. So we're going to go inside a hospital to see the incredible, detailed journey they take to protect these precious medicines. You'd probably guess it's a pretty straightforward decision. Doctor sees infection, doctor writes prescription. Done. But inside a hospital, that one single decision kicks off this whole, carefully managed life cycle, governed by a series of really precise checks and balances. So let's follow the trail.
So before we can even start to follow the prescription, we have to meet its guardians, the Antimicrobial Stewardship Team, or AMS for short. Think of these folks as the mission control for every single antibiotic used in the hospital. Their entire job is to make sure the right drug is used for the right bug for exactly the right amount of time. Their work is the foundation for this whole thing.
Okay, so here's our roadmap. We're going to follow the 5 key stages in the life of one hospital antibiotic prescription. First, getting it right from the very beginning. Then, making that switch from an IV drip to a simple pill. Next, fine-tuning the treatment as more information comes in. Then we'll look at the built-in safety stop. And finally, we'll tie it all together and see why this meticulous process is so critical. All right, our journey begins right at the patient's bedside. A doctor has found an infection, and now they need to choose the right weapon to fight it. But here's the thing, not all antibiotics can be prescribed freely. And this is the very first layer of control. See, not all antibiotics are treated the same. They're basically split into 2 groups. You've got your monitored drugs, which are tracked for data purposes, but then you have the restricted ones. And those are the heavy artillery, the powerful, broad-spectrum drugs that you absolutely cannot use without getting an okay from an infectious disease expert first. And here are some of those heavy hitters. You might have even heard of some of these, like vancomycin or the carbapenems. These are the ones that are basically kept under lock and key. And there's a good reason for that. They're reserved for the most serious situations, specifically to prevent bacteria from getting a chance to develop resistance to our last lines of defense. So what that means is a doctor can't just scribble a script for one of these powerful drugs. Nope. They have to fill out a request, they have to formally present the patient's case to an expert, and they have to get that green light. Only then will the pharmacy release the medication. It's like having a mandatory expert consultation built right into the prescribing process. But you might be wondering, what about a true emergency? The system is smart about this. In a life or death situation like sepsis, where every single minute counts, the policy allows a doctor to give that first dose immediately. Patient care always comes first. The approval process can catch up later. Okay, so our patient has the right antibiotic and they're starting to get better. But the treatment plan isn't set in stone. It's designed to evolve with the patient. And the next big milestone is a huge one, getting them off of that IV drip. Now, switching from an IV drip to a simple pill might seem like a small detail, but it is a massive win for everyone. It's way more comfortable for the patient, it frees them from being literally tethered to an IV pole, it lowers the risk of line infections, saves a ton of nursing time, and get this, it can even help them go home sooner. It's a win-win-win. But this switch isn't just a random guess. It's based on very clear clinical signs. The patient has to be clinically stable. We're talking no fever for at least 48 hours with steady vital signs. And just as important, their gut has to be working properly. They need to be able to eat, drink, and actually absorb the medication without any issues. And here's the catch. This switch is only possible with certain drugs, the ones that have what scientists call excellent oral bioavailability. Now, that's just a fancy way of saying the body absorbs the pill version so well that it's just as powerful as getting it through an IV. It's a perfect example of how that very first choice of drug can shape the whole treatment journey. And check this out. This is what it looks like in practice. This is the actual form a doctor fills out. You can see the checklist right there on the form, making sure the patient meets all those criteria for stability and oral intake. This is how a big hospital-wide policy becomes a concrete, real-time action right at the bedside. So far, so good, right? The patient is improving, but the job of that stewardship team is far from over. This next stage is all about precision. It's about using new data from the lab to make the treatment even smarter and more effective.
Okay, so when an infection is first suspected, doctors usually don't know the exact bacteria that's causing the trouble. So they start with what's called empiric therapy. It's basically their best educated guess, based on the patient's symptoms and what bugs are common in the area. Think of it like casting a wide net just to get treatment started fast. But that wide net, it's not meant to be permanent. Once the lab results come back and identify the exact culprit, the real fine-tuning begins. This is where we see de-escalation, which is like swapping that wide net antibiotic for a highly targeted one that only goes after the germ we're fighting. Or if the initial guess was too weak, they might have to do the opposite and escalate to a stronger therapy. This all happens on a really strict timeline. On day 0, a sample is taken for culture before the first dose ever goes in. Then there's a mandatory antibiotic timeout at the 48 to 72 hour mark, where the doctor has to stop and reevaluate everything. And once those final lab results are in, the shift to targeted therapy is made. The goal is always to use the smartest drug, not just the strongest one. Okay, we've picked the right drug, we've switched to a pill, and we've fine-tuned the therapy. Now we come to the final and maybe the most important phase in this prescription's life, knowing when to stop. And this number you're looking at is the key, 7. 7 days. In this hospital system, most antibiotic prescriptions essentially come with an automatic expiration date. And this isn't just a friendly suggestion. It's a hardwired safety net designed to prevent treatment from going on for 1 day longer than necessary. So here's how it works. On the 6th day of therapy, a clinical pharmacist literally goes and physically stamps the patient's chart with a stop order. This is a formal alert to the doctor that says, hey, tomorrow this medication stops, unless you actively review this case and decide it needs to continue. It forces a deliberate choice, which is so important for preventing antibiotic courses from just running on autopilot. But, of course, medicine isn't one size fits all. The policy has smart, built-in exceptions for those deep-seated or really complex infections that we know require longer treatment. Things like infections in the bone, the heart, or the brain. This just shows the policy is designed to be both strict and intelligent. So, we've walked through the entire life of a single prescription, from the very first choice to the final stop. But why? Why go through all this trouble? Let's zoom out and look at the big picture. This is why. This is what it's all about. This isn't just red tape or pointless paperwork. Every single step we've just seen, the specialist approval, the switch to a pill, the de-escalation, that automatic stop order, is a deliberate action. It's a whole system designed with 2 absolutely critical goals in mind. Give each individual patient the best possible outcome and preserve our most valuable medicines for everyone's future. You know, seeing this whole journey really shows us that an antibiotic prescription isn't just a single event. It's a process, a life cycle that needs careful management from start to finish. And that leaves us with a critical question, one that extends way beyond the hospital walls. Knowing just how precious these drugs are and seeing the incredible effort it takes to protect them, what's our role in being better stewards of the antibiotics that we all rely on?